Good evening and welcome to Rural Medicine Grand Rounds. I'm Dr. Stuart Glastonbury. Tonight's case is on drug seeking and drug abuse presentations in rural general practice. Discussing our case tonight, we have Dr. Steve Cramb, Clinical Director of Alcohol, Tobacco and Other Drug Service at Toowoomba Base Hospital. On my right, I have Dr. Kathy James, General Practitioner at Clifton Medical Practice and Medical Educator with Queensland Rural Medical Education. And also with us tonight, we have Dr. Maxine O'Brien, Senior Psychologist at Alcohol, Tobacco and Other Drug Service at Toowoomba Hospital. Please welcome our specialist and expert panel tonight. As usual, we're being live streamed around Australia. You can join the discussion by emailing your question to media@qrme.org.au, or you can use the hashtag on your screen now. Our presenter tonight is Dr. Stephen Smith from the Clifton Medical Practice, and his presentation will be on drug seeking and drug addiction presentations in general practice. Please put your hands together for Stephen.
Yes, good evening ladies and gentlemen. A special hello to all those watching tonight on the internet. Yes, I'm going to speak to you about drug-seeking behaviour in the general practice context. I thought I would speak a little while about drug-seeking behaviour in general and then present a case that both myself and my other colleagues at Clifton Practice encountered earlier in the year. Okay, so a good working definition, which I found in my research for this topic, was drug-seeking behaviour describes the presentation of people who are falsely reporting symptoms so that they can obtain a prescription or a drug in order to maintain their dependence. So this is a pretty good sort of working definition, but it's certainly not always the case, as we'll find out a bit later. So what drugs are these people often after? Well, opioids are at the top of our list, such as oxycodone and fentanyl. Benzodiazepines come a close second. Also stimulants are quite popular, like ephedrine and the amphetamines. And to a much lesser extent, anticholinergics and anabolic steroids are also sought. Why and by whom? So the most common reason, of course, is most prescription drugs are obtained so that they can be consumed by the person requesting the script, either for the purpose of euphoria, such as with opioids, or sometimes for the purposes of to help along with their job, like shift workers and long-distance truck drivers often seek stimulants. And also a very important and probably growing reason is for profit. The illicit drug market in our community, especially in benzodiazepines and opioids, is quite big, and there's a lot of money to be made. Anticholinergics also play a role here, but to a much lesser extent. We should also be very mindful of the occasional drug user. There's a lot of people out there who are seeking medications like benzodiazepines for occasional use at parties and whatnot. And these people are often quite difficult to detect because there's no regular pattern of their drug use. There's said to be 4 groups of drug takers. Group number 1, they're patients that are known at the practice and they're dependent on opioids. And this is often as a result of treatment by doctors for chronic pain issues. Another group of patients, they're known to the practice and they're dependent on benzodiazepines, and they've often been using them for a long time, and they're keen on keeping their supply going. Third group are patients that are unknown to the practice and they're looking for opioids. These people are usually much younger and more often than not they're physically dependent on opioids. Then the last group are also a group of younger people, and interestingly they're not usually physically dependent on benzodiazepines, I said, and they're more likely to be seeking them to sell on and make a profit on the black market. We should all be on the lookout for behaviour that may indicate that a certain patient is drug seeking. Some of the common things are these people will present near closing time, often without an appointment. They'll be just there to get that quick script doctor after work and things like that. And quite often they'll be asking for a specific drug, and they're usually resistant to change. You know, any other alternatives that might be presented are usually rejected for a multitude of reasons. And we also should be asking whether their symptoms appear to be consistent with their clinical presentation as well. Do they look like the kind of person who is in chronic pain? Are they fit and healthy? And like obviously if they look in tip-top shape and they're reporting chronic back pain or chronic knee pain and they're moving well, you should be asking yourself questions. Another thing, quite often they say they've recently moved to the area, and for whatever reason their records from the previous practice they were attending are difficult to obtain, and they can be quite creative as regards their reasons. I've heard everything from the previous practice that they were attending to, there was a fire and the records burnt down, or it's in the mail, and so forth. We should also be looking for signs of drug use. Obviously, if we should be on the lookout for those patients who are intoxicated. Like with benzodiazepines, you might see sedation and impaired coordination. But we're probably more likely to see signs of benzodiazepine withdrawal, like irritability and tremor and anxiety. Opioid users, if they're high at presentation, will have constricted pupils, and often they'll be scratching themselves. They'll say they've got itchy nose or face or skin. Of course, injection marks are quite a dead giveaway. With opioid withdrawal, you'll probably see dilated pupils, tachycardia, they'll be yawning all the time, and they'll complain of muscle cramps. And quite often they'll have runny eyes and nose. We should also be on the lookout that opioid-dependent patients also be asking for benzodiazepines, because they'll be aware that their opioid supply won't always be constant, and they'll need reasonable quantities of benzos to tide them over until they can get their next fix. Okay. So, questions to ask yourself. Is the drug used for a legitimate medical purpose? Does the drug improve the quality of the patient's life? And are we helping the patient maintain control over this use of this medication? Are the dosages staying about the same, or are they just going up and up and up? And of course, quite importantly, legality. Is the use of this drug uncomplicated by illegal drug use? For example, people asking for pseudoephedrine, you know, we should be really suspicious of those, because that's the #1 way that amphetamines are produced in this country. Also, the pattern of drug use. Is it one appropriate? Are they using medicinal dosages, or are they more intoxicating dosages, more consistent with euphoria? So that brings us on to our case. In early March this year, BS was a 33-year-old woman. She was well-dressed, well-spoken. She had her left arm in a sling, and initially she presented in the early afternoon. She spoke of a complex history of chronic back pain due to a work accident, but her arm in a sling that day was to an unrelated incident. I think she said she had it trapped in a gate. She was quite, she managed to point out the scar on her abdomen. She said this was due to surgery because of a perforated ulcer secondary to excessive use of non-steroidal anti-inflammatories to control her chronic back pain. Hence, that's why she has to use opioids to keep her pain under control. And she was new to the area, but it's okay. The records from where she was previously treated are on their way, and she's filled out all the forms. She discusses the ongoing legal issues associated with this work accident and the current treatment regime by a pain specialist in Brisbane. And she's quite hopeful as regards this surgery that's due at a private hospital in Brisbane in the following month. Her list of current medications included fentanyl patches, and she was quite particular about the brand of fentanyl patch as well because of previous skin irritation issues that she's had. And she went to great pains to point out that she really doesn't like to be dependent on opioids. Early April, she presented requesting a flu shot because she certainly didn't want to risk getting sick before the day of her big operation later on in the month. And during that presentation, she also, as almost as a side issue, requested her usual scripts, including her fentanyl patches. And she just couldn't understand why her records hadn't arrived yet from the previous practice where she was being treated. She was hoping they would because she wanted to facilitate optimal post-operative care. End of April, she presented to a different doctor practice. She says she's now had her back surgery and her post-op recovery is going well, and she has an upcoming appointment to see a pain specialist to hopefully get her off the narcotic analgesia. And but in the meantime, she needs her usual scripts. And it's quite unfortunate. A few days later, she reports losing her scripts, and she obtained replacements. We were all quite surprised at our practice that the 31st of May, we got a letter from the Medicare doctor shopping department stating that BS had been to 25 different doctors within the area. And she obtained 24 scripts for fentanyl. So that was 147 patches in total, as well as scripts for diazepam and amitriptyline and esomeprazole. Then subsequent checks, we phoned the Wesley, and they had no records of this patient. And not surprisingly, she hasn't been back to the practice since. As I understand, she would have received the same letter we did. So thank you very much. That concludes my case presentation. Thank you.
Right, okay, thanks, Steve. I think one thing that I can take from that is at least she was using her omeprazole. So she was looking after her stomach while she was on all...
She was. Yep.
So I guess, I mean, it's an amazing case. I guess I'll start by just throwing it open to the panel and say, how was this woman so good? How did she fool so many different doctors in such a short period of time?
I think this case is probably quite an atypical presentation in general practice, in that, to me, this has all the hallmarks of a well-planned scam. And the presentation is so good, isn't it? She's, as you say, you were surprised. Even after there were 2 yellow flags in that, she asked for a specific drug, she had a replacement script, but you were shocked to discover that this wasn't all on the level, as I'm sure were the other 25 practices. But there are a number of indicators that she's had that she is on the level. She's given you background history which would be verifiable. You could have contacted the Wesley right from the beginning, but you didn't. But she's provided that information. She's come in with another injury which she is not using as an excuse to get additional pain relief. And that's quite reassuring, isn't it?
Oh, yes. Yeah. She was very good at obtaining sympathy from the guy. The arm in the sling, the scar, which could have been from anything, really.
Well, quite possibly the scar was from having taken excessive non-steroidals, but that wouldn't normally be at a therapeutic dose, would it? It would often be at a super therapeutic dose. But I guess the thing that, the whole thing fits together so neatly, that she's either developed this herself and become very practiced at it, or she has been schooled and scripted by somebody else. Either way, this is I'm sure if you contacted any of those other surgeries, in fact, the 25 other surgeries, you probably just phone any surgery at random in the Toowoomba region, couldn't you? You would find that she's presented with exactly the same story and exactly the same presentation with the arm in the sling and so on. So we certainly do see cases like this. We had another patient who had done something similar, had actually been around about a year with a surgery in Toowoomba here, receiving regular clockwork monthly scripts, had one early repeat, and for whatever reason the registrar had an open ear and had referred the person on to ATODs. The name was familiar, but when we inquired further, the person that we knew was Indigenous, and this person was not. And So what it transpired was we had a case of identity fraud going on. And so that person never presented to ATODs for review and never went back to that surgery. But how do we track that person? We knew it wasn't actually her identity that she was using to obtain these scripts. There was a far more complex, but again, more time limited, like your one. One that I heard about happened up at the Sunshine Coast, where a group targeted a particular practice and advised that, contacted the practice and spoke to them. That somebody called and said they were from the Australian Federal Police and they were arranging a sting, and they wanted the surgery to not intervene on the group of people who were going to come through in the next few days asking for drugs. They wanted to catch them red-handed. And the doctor quite appropriately had some concern about that. He felt hook, line and sinker for it, but having some concern about what this might mean for his professional practice, contacted the Drugs and Dependence Unit, now the Medicines Regulation Quality Unit in Brisbane, and asked them, just let them know that this was going to be happening so that they wouldn't hold it against him. They put him through to their investigations officer, who's a former police officer, who contacted her contacts. And they did, in fact, as it turned out, the Australian Federal Police did run a sting and picked them all up as they came through the door. They weren't wrong, I mean, it was false, but when the information was passed on, they did arrest them.
Do you think my lady would have been using these medications herself, or do you think they'd have been extracting the fentanyl and selling them for profit?
I think it's hard to know whether she would or wouldn't have been using them, with the suggestion that she might have had an excessive dose of non-steroidals, presumably accompanying codeine. She may well have been opiate dependent herself, and that gives something for a dealer to hold over her. But I would suspect that the vast bulk, if not all of those fentanyl patches, went onto the black market.
So, I mean, you know, Steve's shown tonight in the presentation that there's lots of different drugs that are used as for, you know, that people seek as drug abuse. And we have had a question coming in from the audience about fentanyl patches, particularly then, and extraction from those. So is this an easy thing to do? I mean, is this something that, you know, I mean, it seems to me like a lot of work, to be quite honest, but maybe it isn't.
To extract the dose from the fentanyl? No, it's work of about an hour with a simple chemistry that you can buy down at your bottle. No, it is quite straightforward. We don't have to go into detail at how to do it tonight. Just,
it's freely available on the web.
Yeah. www.fentanyl-extraction.
It would work. Certainly fentanyl has hit the media lately. And that will tend to increase sales in the street. If you say that something is dangerous and people are likely to die and you shouldn't do this, people immediately go and do it. Okay. And that's actually been used by drug dealers in other countries to get their drugs sold. They sell market their relatively benign drugs as being lethal, and therefore people buy more of it. But the fentanyl certainly is lethal. 100 microgram per hour patch is giving you an anaesthetic dose every hour. Yeah. And so people do die on the end of a needle. Most people I've spoken to locally who are abusing fentanyl are using very inefficient extraction techniques. And that's actually in some ways dangerous, because it means that only a small increase in efficiency will increase the dose quite considerably. So we've had people come to us who've had multiple presentations to rural hospitals following overdoses.
Can I just say, I think it's really great that you presented a case where the outcome has been bad. You know, like you suddenly realise that you'd been majorly scammed. And I think that that's going to happen to all of us at some point, you know, in our clinical practice, because sometimes people are just very skilled, you know, at their presentation. And I think it's worth looking at, you know, some of the things that can maybe help reduce us falling victim to some of these kind of approaches, and particularly, you know, for new patients when they come in. I think it's really important to think about slowing down your response to their request, and that sometimes you can have in your waiting room a sign where it says, you know, no Section 8 drugs are going to be prescribed here on your first visit, really useful. Don't feel pressured or intimidated or hassled to prescribe. There's no urgency. You need to take the time that you need. And obtain the extra information that you need. Really important to get a good history, you know, where have the last treatments been done, the last prescriptions been done, who are their GP or GPs, where is their specialist based. You know, spend that little bit of extra time to get that information. I think it's really important to have a little banned list of drugs that you personally just will not prescribe. And so for me, I've got 3. Duramine or amphetamines for adults, alprazolam and fentanyl. Fentanyl is a hugely powerful drug, more than 30 times more powerful than morphine. So if someone comes in with those drugs, I'm just automatically going, there's something that I really need to take note of here. And I think taking the time to also say no to patients takes a bit of practice as well. So to kind of say, no, I'm not going to give you this drug. You're not only kind of establishing a bit of control over the consultation, you're also kind of giving them messages that you understand what issues are here, and your street cred is really important in the world of drug-seeking people, because when you're a new doctor and you move into an area, the information of you arriving in that practice spreads faster than Twitter. You know, like, it is just amazing how that message gets passed through the community. But equally, if your street cred is that you understand about drugs and you're not easily kind of rolled over, that spreads really quickly as well.
So, you know, it's my understanding that this is one thing I think that new registrars, especially getting out in rural areas where they may not have, you know, great support and those sorts of things, really fear this kind of a presentation or don't have a good way of dealing with it. And I think that those points that you outlined are really, really good. You know, would you routinely call DDU, or is there, you know, is that something that you would do before, you know, before you would prescribe or routinely? Is it worth it? Is it a reasonable thing to do?
The Drugs and Dependence Unit, as they were, Medicines Regulation and Quality, do advise people to do that, and they have an initial screening number. When you go through, you go to an advisory service, and if you need further clinical advice, they pass you on to the Medicines Regulation and Quality themselves. But yeah, so you can phone up, and in a situation like this, it may or may not have shown anything, because I think this has probably been a deliberately time-limited scam. But for most people, you should be able to get a track record. So if somebody is on fentanyl and they've had this pain and they've had it for a number of years, you will be able to call up and they'll say yes, in fact they've had 5 prescribers of this medication over the last year, and they're getting an average dose of this, and the scripts are happening and at a time interval that seems appropriate or doesn't seem appropriate.
I mean, we've talked a bit about fentanyl tonight. Are there any other kind of red flag drugs that you... I mean, Kathy, you mentioned that you had your sort of ones that you are very wary about. Are there others, sort of red flags, that often are the ones that, people who are going to be drug abusing or drug addicted, I guess, as well, would be generally seeking?
If it's an opiate, it will be abused.
Okay.
And there's a whole question around what the role of opiates in long-term pain relief is. And I think this is something that, in general practice, we are unfortunately lagging behind the pain specialists. The pain specialists have moved on. They do not like to use opiates in the long term for anyone, if at all possible. And we're still on the paradigm that pain medicine was operating in 5 to 10 years ago, where if you've got chronic pain, have some more opiate. Number needed to treat for opiates for benefit in pain, short-term benefit in chronic pain, is probably about 4. So 3 out of 4 people that we're giving opiates to are not really benefiting from it. And that's for short-term analgesic benefit. If you look at things like quality of life that you were asking about, we've actually got no real evidence at all that opiates improve quality of life. In a number of situations, acute management with opiates will deteriorate long-term quality of life. So we need to be really, really careful about any opiate. But given that it's an opiate, the more potent the opiate and the shorter acting the opiate, the more the problem. And so out of out of the opiates that we commonly use, fentanyl is the most potent and shortest acting. The other common ones that you would see would be morphine, oxycodone. The oxymorphone, I think it is in a Genista, is also abused. I've certainly seen that, despite the fact that the company imply that the delivery system is essentially uncrackable. I've certainly seen people abusing that. Yeah, if it's an opiate, it will be abused. So we just need to be, I think, cautious around anything at all, from over-the-counter codeine on through.
I mean, it's interesting just taking up on that point about being quite far behind the pain specialists in that area. I guess certainly it's easy to fall back on an opiate for pain, I guess, and if people are pressuring and they've got a good story, or that then that I understand the holistic management probably is a better pathway to go to. Although I understand that it's probably one of the more difficult ones, and yet I'm sure that Maxine, working at ATODs as well, that the psychological role plays a very integral part in all of that. In fact, I would have thought that maybe even more so than the medications, I guess, maybe, or at least alongside. Yeah.
Definitely alongside it.
Yep.
And I think that a lot of what we've been talking about with the difficult doctor shopping stuff is more about the black market and or sort of clever money-making end of the business. And really the vast majority of people are probably addicts, and we're dealing with addiction. And that's a whole, very holistic kind of approach that probably takes a lot of listening, very person-centred sort of approach. There's lots of theories in psychology and models about what addiction is from a psychological perspective, but they overlap in certain ways. But what I see in most of the people that we see at ATODs anyway is basic human learning theory, that people are looking for reward, and they get rewarded by their use, either because they gain euphoria, or they gain some street cred with their friends if they're very young, or because they escape from some pain. And certainly the people that are in treatment in the psychology team at ATODs are experiencing significant distress from mental health issues. The vast majority of them probably have experienced some kind of interpersonal trauma, particularly sexual abuse in childhood is a very common presentation. Those that don't enter an addiction with a pre-existing sexual or interpersonal abuse will commonly experience that once they become addicted, because of course if you're intoxicated and you're living on the streets or in the drug scene, you're very vulnerable and open to that happening. Yeah.
I mean, in a regional area like Toowoomba, I guess, and Kathy, I think you've worked in more remote areas as well, and I think in New Zealand too, where you've worked as a GP. Is there a difference in the kind of the demographics in kind of urban and kind of then rural and maybe even remote areas as to what's being used and what's being sought as drugs of dependency or drug-seeking behaviour? Is there a difference in the demographics? Because we have registrars who are, in these different areas, and I guess that would be interesting to know. Yeah.
I think it goes a bit in cycles sometimes, that might get an outbreak of speed use was really common out west for a while, and that became a big problem. And now I'm hearing more out west, it's more oxycodone has become more of an issue. So I think it tends to be a bit kind of sporadic and follow trends and availability. Yeah. Okay. But I think, so I was going to just say, if you took the next step of your patient, say if she'd actually come back to you and that you were then faced with talking to her about the fact that you'd uncovered her drug use. I think that's the next interesting step about, how you have that conversation with someone. And I think people who have addiction often get very poorly treated in health services, and they tend to see health very much in the same light as they would see justice and the police, and have a very negative experience. So, and I just think what Maxine was saying about the incredible trauma that many people with addictions have had, and the kind of suffering that they get in their life, where they often have lost relationships with significant others and family, they've lost employment, they've maybe lost their housing. So you're dealing with people that, although we say that people have aberrant behaviours when they're addicted, the other way of looking at it is that it's actually highly adaptive, because they've got to struggle, they've got to survive in a very adverse environment. So I think when you're looking at people who are coming in to your practice, and just to think a little bit about providing some empathy for them about what's going on, and when you're dealing with a person who's, say with this woman who's coming back, and you want to kind of have an open, non-judgmental and respectful conversation with her to say, look, I understand that there are some issues with you obtaining these drugs, and I'd like to really know about what your history of drug use is really all about, because she might not necessarily be using the fentanyl that she's scamming, but she might also have a significant addiction in her own right. And I'd be really interested to know, you know, can you be honest with me and tell me, you know, what is actually going on in your life? And then be clear with them about your limits, you know, to say things like, well, you know, I know that you have an addiction, it's now illegal for me to prescribe for you, but I can help you work through the issues around addiction. And it's too much for a GP to do just on their own. You really have to think about, you know, your practice team, but also reaching out to people in the drug and alcohol services. And of course, I'm here with the ATODs team, whereas I also work part-time with ATODs. And Jen, sitting in the audience there, just the importance of, you know, sometimes making that call to the nurses who are in drug and alcohol service. They're highly skilled, and they can often give you a great kind of great ideas about, you know, how you might want to proceed, and offer to see the patient for you. And I don't know, Jen, do you want to talk a little bit about, you know, some of the calls that you might have got from GPs, or how you could help when someone calls you?
Thanks, Kathy. I guess from a perspective of one of the nurses at ATODs, we would certainly help any GPs or general practitioners or other doctors assist with patients who do have drug dependencies. We would organise for them to come in for an assessment. So the nurses often will do the assessments, and we'll be looking at when they have first started using any sort of substance. We'll be looking at their mental health, we'll be looking at any social issues, we'll be looking at child protection, children, families, a little bit about some of that trauma, just to get a bit of an idea about what we can do. We would then maybe speak to the medical staff that we do have to gauge whether we need to act quickly, or if we do have a little bit of time with booking somebody in for an appointment. We may get collateral information. Sometimes we can have information from the hospital charts, and we can see what accident and emergency presentations people have, or what other information might indicate that there is drug dependence or intravenous drug use, that sort of thing. We will often speak to the old drugs of dependence unit to get that collateral. We might speak to the different GPs. We might let the doctors know that someone has got an appointment date on a particular date, so they know that things may change from that particular time. If someone was found to be suitable for an opiate treatment program, we would liaise with the doctors about maybe when medication might need to stop, and when ATODs might need to start to take over. So once all that has happened, we would then continue to case manage the clients. We would be looking at being very supportive, like Maxine and Kathy have said. We're non-judgmental, we offer very supportive environment, and we really look at relapse prevention strategies that people can achieve in a very slowly way, and it is as long as it takes. So at ATODs, we're not a 6-week service. We might case manage some clients for, 10 years, 15 years. As long as it takes, we're there. So we find that's really helpful for clients, because they've got someone that they can come and talk to, someone they can develop a rapport with, and that can really help settle things down.
Yeah. That, I think, again, for registrars feeling very alone in this kind of an environment, it's good to hear kind of the different perspectives and that idea, especially from the nursing perspective as well. And I think too, and my understanding as well is that a lot of people who perhaps, you know, I guess, not drug seekers so much, but definitely people who are addicted to whether it be pain prescription medications or otherwise, often maybe don't want to go into ATODs or into a major centre and they'd like to stay in the community. Do you know of programs, or is that sort of happening at the moment where that clinic nurse kind of takes on that role? Is there kind of a statewide program or any programs that sort of look at that you're familiar with? Sorry.
Really what we try to do is have people come in for appointments,
Yeah.
and if they do live in rural areas, we can do video conferencing, we
Okay.
can link people up.
Yep.
We've got workers who are in the rural areas
Yep.
as well. So we do try to do the best thing for the client. Some people can't come in, we might do telephone contact, but it is good if they can come in because you do start to develop a better rapport and you can see people. But we do try to, you know, be a little bit flexible with how we see people as well.
Well, one of the things I just wanted to just bring out was that there's a huge repository of knowledge in the nursing staff at ATODs, and if GPs were wanting to self-manage an issue, I would actually choose to call one of the nurses and have a talk with them and just see if you can manage, you know, the issue from the discussion that you're having. And the nurses work as a multidisciplinary team, so they talk with psychologists, doctors, and, you know, can sometimes make plans that then the GPs can then go on and carry out.
Absolutely.
Yeah.
I think the initial assessment is really important. In particular, when you're dealing with addiction, one of our first questions is, where is this client in terms of their stage of change? If the person isn't yet ready to deal with that addiction, the harder you push, the harder they're going to pull, and all that's going to happen is they'll disengage from the service. So job one is to keep the client engaged in treatment, and that's all about developing that rapport and trust and mutual respect with the client to keep them coming back.
So we've got lots of good questions coming in. We've got one down from the front row here.
Hello, I'm Andrew. I'm from Stanthorpe, medical student out at Stanthorpe at the moment. My question is related to what we're just talking about. I find it very interesting to think about the concept of a drug seeker being caught in the act and not racing out the door. I just always assume that as soon as they're, you know, confronted about the issue, that they're just naturally just going to scream and yell and run out the door. But obviously there are instances where you can capture their attention and capture them in a therapeutic relationship, and I just want to know what sort of practical ways you've been able to do that personally, or you know, suggestions on how that can be applied in practice.
I can speak from my experience as a GP registrar a few years ago. I'd worked in drug and alcohol before doing my general practice training, and so I suppose my eyes and ears were a little bit more open. I probably came across at least 4 or 5 patients in that situation that then engaged in treatment. It's about saying to somebody, I see that something's happening, this is concerning to me. I've seen people who've had this sort of situation before. It's often been that they've found that they couldn't get away from this substance. People are universally ambivalent about drug use. There's nobody who feels perfectly happy about their drug use. There's also probably nobody who feels perfectly unhappy about it or they'd stop it, but they are ambivalent. And so tapping into that ambivalence and saying, but if you're looking at doing something, this is what we would do. I can get you to go and talk to the nurse who comes out here once a month or once a fortnight, or however often the ATODs nurse gets out to Stanthorpe. Or I can arrange for you to go and see somebody down in Warwick or see somebody in Toowoomba. We are going to stick with this. This isn't me throwing you out, far from it. This is me saying I'm prepared to be here and work with you, and we'll see where we get with this problem. I have a sense, particularly with the opiates, that most people that really get hooked on it have a lot of pain. And it might be psychological pain rather than physical pain, but that's what got them here. So committing to sticking with it and working through that is important for people. But if you indicate that you're not going to, lose your temper and say, "Begone, never come back to this surgery ever again," people are surprisingly willing to engage.
So we've just got a question come in on Twitter, which I'll take, and then we'll go to the audience. So just a question to the panel in general: is prescribing reduced quantity scripts, if unsure about a patient history, helpful to differentiate the genuine new patient versus the drug seeker? Is that an approach you could take?
I don't think it differentiates them, but I think it definitely gives you control over the situation.
Yeah.
And I would use that all the time, that I would be limiting to daily prescriptions, daily pickups at the chemist that I nominate until I've clarified the situation. And I'd certainly use that if I was in a situation of being extremely intimidated and fearful of violence. I would probably use the prescribing one pill, pick up, today. When you're feeling better, I'll see you tomorrow.
One of the some 24 doctors took that approach, hence the odd number of fentanyl patches.
All right, so we'll take a question from the audience now.
So my name is Andrew. I'm currently an intern at the Toowoomba Base Hospital. My question is for all of the panel, and I am lucky enough to have, or if our team needs access to ATODs, we get it pretty quickly, and it's an excellent service. It's quite a labour-intensive service, and I wonder whether you mentioned going out to Stanthorpe and Warwick, but I wonder if you go further west, whether there is that support for GPs away from Toowoomba or away from a major centre, and how a GP or indeed a rural area nurse might deal with these problems if they don't have access to ATODs.
The fragmented nature of acute treatment services in Queensland, we've got, 13 hospital and health services now. Each of those geographical areas will be running their services differently. So I can't really speak for what happens precisely outside of those boundaries. We, as far as I know, every hospital, if you've got an inpatient, you within the Darling Downs Hospital and Health Service, you should expect to have some accessibility to an ATODs clinician. And then there's always the video linkage. I'm aware that there are ATODs clinicians west of that, and east if it comes to that. So I think, broadly speaking, there's some availability. Now that's going to differ, practically. If you're in Gundawindi, you'll get a face-to-face visit from somebody, but it'll probably only be once a month. If you're in Toowoomba, if long as it's a weekday, you can pop in and see ATODs yourself without an appointment. So yeah, it does vary depending on location, but it is available, and we certainly take phone calls all the day. I had a phone call today from a GP in Gundawindi asking about a pregnant woman and wanting to manage a drug use issue there. And that's a routine part of our day.
And can I follow up? And sorry to ask whether it's once a month or once a week, would that change your approach, or the approach you'd recommend to the doctor in terms of how they approach the situation, or not necessarily?
I think that there's no particular skill involved in drug and alcohol treatment that isn't available to a general practitioner. What we probably do a little bit differently to general practice is we'll spend time. Spend time in a block. Just take an hour and a half history from a patient, examination. Do that all in a block time, which you won't have available to you. On the other hand, you've got the opportunity to see the patient again and again and again and again and again and again, which we won't have in quite the same way. So you've got to utilise that. But the skills in terms of motivational interviewing, judging whether people are ready to make a change or not, and how to move them along that progression, work with their ambivalence. They're things that you're doing all the time with people with hypertension and diabetes and exercise and diet. You do it day in, day out. So those skills are available to people. If you've got an immediate access to somebody that you can, I can make an appointment for someone to come and see ATODs in Toowoomba here, we're still probably going to be a week or two away because we've got a backlog. If you've got somebody who's coming out and visiting, you'll probably be able to get them at the next visit. Maybe that's tomorrow, maybe that's in 3 weeks' time. It'll be whenever it is. But it's going to be a backup to what you as the GP are doing anyway. It shouldn't replace what you're doing.
Scott?
Steve, thanks. Further to that question, I'm just wondering whether or not there's the availability of telemedicine consults to an ATOD specialist. Do they attract the Medicare? Do you have the setup for it? Is it feasible?
An excellent question. Up until the present point in time, we don't have a recognised specialist in ATODs. I'm a specialist general practitioner. Kathy works for us part-time. She's a specialist general practitioner, and the other senior medical officer we have is a general practitioner, not a specialist general practitioner. But as you would all be aware, that specialist in front of the general practitioner doesn't entitle you to be the kind of lead person in that sort of consultation situation. Starting from about 2 to 3 weeks' time, there will be an addiction specialist, a psychiatrist subspecialised in addiction, who will be working at ATODs, and certainly there will be the opportunity for that sort of video consultation. We have the facilities for it. We do a lot of video consultation now, but that would more be with having the doctor in Toowoomba and the patient in Gundawindi or whatever.
It sounds like, I mean, we have lots of registrars streaming tonight from all around Australia, and I guess from wherever you are, you'll have a similar sort of service. And telemedicine, I guess, will probably be a big area of this into the future as well, being able to link in with a specialist in an area. Absolutely. We'll get a question from Megan.
Megan O'Shaughnessy from QRME. I just have a question. If you're a registrar in a GP practice and you see a patient who normally sees one of the partners who is on a long-term opioid script that you are reluctant to supply, how do you approach that as the registrar? A, do you supply it? And B, how do you speak to the partner on his return?
Good question.
I'd like to say I wasn't the first of the 2,000 GPs. She did have a number of old scripts with her to guide the dosages of the fentanyl, which, funnily enough, were the strongest patches you could normally get.
I think one of the important things in dealing with people with drug addiction in general practice is that the patient sees the same doctor and doesn't move around the practice and see lots of other doctors. I think that's probably one of the most important things, particularly in terms of setting boundaries and developing a really secure therapeutic relationship with the patient, because this is a chronic relapsing condition. This is not something that gets better over time. So you really have to kind of work on that relationship. And I think that if the registrar feels uncomfortable, they should reschedule the patient to come back to see their regular doctor, and that should be done, and just feel quite comfortable about doing that. The other thing that registrars have is that they are a fresh pair of eyes coming into practices. And it does give them the opportunity to review all patients that they see in terms of their medication list. And sometimes people get fatigued and they just tick out the same medicines and things get prescribed again and again for the same person. But a new person coming in, it's a great opportunity to do a medication review. And then in that context, you can meet with the supervisor and say, look, I've done a review of Mrs. X and I was wondering about this opiate, and I talked to her and she thought she might be able to decrease it down a little bit, and would you be happy for me to embark on that management plan with her? I think that's a great opportunity for the registrar.
Okay, so we are almost out of time, and as usual, I guess I'll take it back over to Stephen. As you started the case, what kind of, from this case, were there any particular lessons that you could discuss in? We've got a minute.
Well, my alternative title for this talk was You Can't Judge a Seeker by Their Cover. I've come across a number of people looking for narcotics, especially as I did my intern and residency in a outer suburb hospital in a lower socioeconomic environment, and they were virtually all the stereotypical, unkept, badly spoken, sort of insisting on just want drugs. And this was very different. And if we would have had more time, I would have liked to have outlined another case who some of the staff in our practice thought this fellow was looking for narcotics, but he wasn't. He checked out. He looked like the stereotypical drug seeker, badly done tattoos, unkept sort of fellow, and And his story checked out 100%, and a lot of his... he was very open to alternative suggestions to analgesics, and one thing he did say to me, I don't want any more of that MS content stuff, Doc, and I've never heard that from anybody seeking drugs before. And I've got him onto Targan at a much reduced dose now, and he's been doing very well on it. And so, yeah, I'd certainly check out their the background history a little bit more and take the time to make 1 or 2 phone calls.
Okay, so we're out of time, unfortunately. I think, again, lots of learning lessons there, and I hope that the audience and those people streaming live tonight have learned a lot from our expert panel. So thank you, Stephen, for your excellent case presentation, and thank you to our specialist and expert panel tonight.